So we had to kind of come off of that platform, at least that account. But I maintained a private account, and so I just asked everybody to flip over to that one. It looks like a whole bunch of people did, so thank you for joining us over there. The phone that's on that account is precariously positioned, so if it tilts over, it's my fault because it's kind of sitting on the charging cable at the moment, guys. Okay, so I think we're kind of ready to go. Hopefully people are joining on both accounts. I hope you guys have all been well. Welcome back to Fertility Fact or Fiction, the live show where we answer all your questions and always go over a topic to discuss whether or not that topic is relevant and makes sense. We have multiple cameras. I'm actually looking at 3 different cameras here, so if I'm not looking directly at you guys, forgive me. It's because I'm looking at each of these different cameras. And we will definitely try and attend to everyone asking any questions. So tonight's topic was whether or not Hcg, the human chorionic gonadotropin, the pregnancy hormone, which we typically use as a trigger shot to induce ovulation, can actually improve the chances of success when doing intrauterine insemination. So I know we talk a lot about IVF, but actually we do a lot more IUI, intrauterine insemination, than we do IVF in any program that you go to, mainly because the costs are so much lower, unless you're in a mandated state in the US where the insurance companies have to cover the cost of IVF. So because we do a large volume of IUI, I always felt it's important to touch on those topics as well. And this one was really important because there are 2 ways to do the insemination process. One is to allow a patient to either make eggs naturally or with medication, and then release the eggs naturally, which some people believe is sort of beneficial or a better option. And then other option is to actually trigger the release of the eggs. And there is actually a third option, and that is to let someone naturally trigger and do the triggered option with adding in the Hcg. So as a follicle develops, it starts out relatively small. Usually you'll start being monitored around day 3, or in some cases we just allow people to use an ovulation predictor kit. When the egg is getting ready to be mature, either based on ultrasonographic evidence of its size or hormonal evidence that it's beginning to release, you then have the option to allow the egg to surge and release on its own because your LH hormone spikes, and that's the signal to release the egg. Or you can do this via, you just came undone there. Or you can do this via the option of adding in an Hcg trigger, and that Hcg trigger will allow you to force the egg to ovulate. And that's often important in someone who's got anovulation or oligoovulation, for example, women with polycystic ovarian syndrome. So the question was, is one of those 3 choices better? Allowing you to naturally trigger on your own, allowing you to trigger exclusively with the use of Hcg, or to do both at the same time? And so I started doing some research for this because I really wanted to answer the question for myself. And it turns out that there's actually a really great Canadian study from some of our near and dear colleagues in a nearby clinic in the Hamilton area. And that's in Ontario, Canada. If those of you who are following us are from outside of Canada. So they ran a study about 3 years ago where they looked at about 365 cases of intrauterine insemination cycles. And these cycles were a mixed group of patients who had either taken clomiphene, which is Clomid, they had taken letrozole or Femera, or they had taken the controlled ovarian hyperstimulation protocol, which are the injectable medications where you're doing the FSH or LH shots, and those are being used to improve the growth of the eggs, the number of the eggs that grow. It also, of course, helps your lining develop too. And so they compared in that retrospective study, so they were looking back at patients that had already undergone the procedure, and they compared in that study what happened between the patients that naturally surged, those that had a Hcg trigger, and those that had the combined trigger of natural and Hcg. Now, it's important to note one critical thing here, and that is when you naturally trigger, we typically will do the insemination 24 hours after. So, for example, we'll tell people to check for their ovulation with a urine stick in the morning, and then if they're positive, they call us, and the next day in that morning, we'll do the insemination. When we typically do a Hcg trigger, we normally allow 36 hours after the trigger because most commonly you'll ovulate around 36 to 40 hours. Having said that, they have done studies that show that there is no difference between a 24 and a 36-hour insemination, so either one is acceptable. We traditionally do the 36, but there's nothing wrong with doing a 24, and that's completely reasonable. So there's good sort of biologic plausibility or believability behind the methods that are being used here. So 365 cycles of IUI that they examined, and they actually showed in this study that when you gave the HCG, it resulted in a much higher success rate. So their overall pregnancy rate was 18.1%, which was 66 out of the 365 patients. And from that 18%, when they sub-analyzed it, they showed that and this was for clinical pregnancy rates, so you're seeing the heartbeat go in the infant on ultrasound around 6 to 7 weeks. So they showed that when you compared the recombinant HCG for the intrauterine insemination compared to just the natural surge, it was 18.2% versus 5.8%. So almost a threefold increase, or more than threefold increase in success rate when you added HCG instead of just the natural trigger. But when you compared patients that got an HCG trigger and they naturally surged, you then got 30.8% versus 18.2%, which is quite a huge jump. So 30.8% for an IUI with letrozole or Clomid is, or even the shots, is actually quite substantial. That's a high number and very impressive. And that was true when they compared it against the HCG only trigger or against the natural trigger. So it was 30.8% versus 18.2% when they compared it against the HCG alone group, and it was 30.8% versus 5.8% when they compared it to the natural surge group. So they then went on and did another analysis looking at just the patients that did the injectables, and when they looked at the patients that just did the injectables, it's a very substantial difference. So the pregnancy rate there was 21.7% when you do the HCG trigger, which we always have done when we're doing the injectable meds, versus just 2.1% when you allow those patients to naturally trigger. So I'm sure some of you are saying, well, natural is better. Why is it like this? So there are probably several theories behind this. Number one, it's very possible that when you're following a natural trigger, your brain is actually recognizing estrogen levels. It doesn't actually know the size of your eggs. And if you have 2 or 3 eggs developing, your estrogen level goes higher, your brain sees that it's higher, and it starts sending the release signal potentially before it's ready. So doing the HCG trigger can further help mature the follicles and the lining to prepare it for the implantation and the insemination, natural insemination. Number two, there are potential effects where there are LH kits, the urinary kits that you're using to test if you're ovulating, and those kits may be false negative. In other words, it's not showing you that you're ovulating, but you actually are, and it can be false positive as well, where it's saying you're ovulating, but you actually are not. So by taking the HCG, you're adding to that effect and getting an improvement in the number of patients that are actually releasing their eggs. So between those different reasons, they're definitely seeing a much more substantial increase in the number of patients who are getting pregnant. And again, those numbers are very substantial, 30.8% versus 18.2% and 5.8% depending on which trigger technique we were examining. So it looks like your best bet, if you're using the shots, is to do the HCG trigger, which we have always done. But they're saying now that your best bet when you're doing the oral medications, letrozole or Clomid, is to allow your body to naturally ovulate, but then also do an Hcg trigger and then show up the next day for the insemination. Yes, you will only be at the 24-hour mark for your insemination, or roughly 24-hour mark from the time that you've had your LH trigger, but you'll actually have a substantial improvement in success, because we know that the 24 and the 36-hour inseminations don't make a difference. So fact or fiction this week was, does the Hcg trigger help in patients doing IUI to improve the success rates? And the answer is yes. It is a fact that the Hcg trigger does improve your success rates. And so because of this research that we've done, we're actually changing our protocol to add Hcg triggers in, even when you're doing a natural stim cycle, or if you're using letrozole or Clomid. Everyone will go home with a Ovidrel shot, which is from our friends from Serono. They make a already pre-mixed vial in a syringe. It's very easy to inject. You'll get your LH trigger from the urinary kit. It'll show you when you're surging. You additionally take your Hcg trigger, and we should be seeing quite a substantial improvement in our already really great success rates. I think this technique, combined with all the vitamins that we use, the close follow-up of the patients, all the healthy habits, minimization of smoking, drinking, drug use, or elimination of them more than minimization. And then in addition, that Zymo technique I've talked about before, where we are using a sperm DNA preparation technique that minimizes the amount of sperm DNA damage. I think altogether those should combine to give very robust insemination rates, and I'm hoping that by next year we may be able to publish something showing that our success rates have really taken a leap forward compared to where they've already been, which has always been good, but I think we can really get them to something we haven't seen before. So yes, it is a fact that doing the Hcg trigger in addition to your natural trigger will benefit you when doing pills, and when you're doing the injectables, you should definitely be doing the Hcg trigger. That is the best way to go when you're doing the shots. So with that, I'm ready to take some questions. Tarek from Ibrahim Strategies Group is here as always, and he's going to be reading to me, and then I'm going to attack Facebook from the camera. So I will start with Facebook. Do you want to start with you, or do you want me to start?
Whatever you want.
Yeah, I can do this. Okay, so hope I'm feeling better. Thank you for hoping I'm feeling better. For those of you that are watching from home, I have kidney stones. My daughter has named them Fred and Harry or something like that. In any event, they're still painful and they're still there. So thank you for the well wishes. I am actually going through the process of being on metformin and letrozole and trigger shots. Interested to see what you have to say. My RE canceled this cycle as I couldn't get in for my ultrasound. That's understandable. To check the growth of the eggs, and advised to just use timed intercourse with the letrozole. So I did not trigger shots. I did not do trigger shots. I have normal 31-day cycles. So actually, that's a perfect example. Even if you can't get an ultrasound, if you use your natural LH surge, which you can detect with those urinary kits, and you go ahead and you do the ovulation induction with the Hcg trigger, so you do the shot to make sure that you are ovulating, it will give you that much more robust response, and you can go ahead and do an IUI if your center is willing to do IUIs right now. I should touch on that briefly. I was just watching, before we started this program, a 1,500 member webinar kind of chat group in the US, and they are moving towards reopening for a number of reasons, especially for high-risk groups like women who have diminished ovarian reserve. There is some detrimental effects to waiting more than 2 months in that group, and we are approaching the 2-month mark soon, so they need to have plans in place. In Canada, we had a conference call with all of the IVF directors last week, and I'm now on the committee to look at the standard operating procedure to reopen all of the Canadian clinics as well. We do not have a timeline as of yet, but the plan is to look towards reopening. I'm sure many of you have probably already heard that in some of the states in the US, they've actually already said that fertility is an essential service and that the decision can be made between the physician and the patients. While we support that, at the same time, we need to be cautious, because it's not just the patients that are at risk. It's your families, our staff, others that are in the environment. and so other patients that are coming, including our obstetrical patients. So this has to be very calculated. It has to be very formal. We got to be very careful on how we do this. Your safety and everybody's safety is our number one priority. But our number two priority is to resume function and make sure that we are treating patients who are trying to conceive. So it was quite an interesting discussion. There were lots of different opinions on both sides as to what we should do. You can throw up lots of likes if you think we should reopen, and maybe send out the thumbs down if you think we should stay closed. So I'm keen to see what you guys all think. I did a poll a couple of weeks ago on IG, and about 68% of patients thought that we should stay open or reopen. I'm seeing lots of thumbs up now as well. So for sure, yeah, I mean, it looks like the majority of people want us to either reopen or stay open, and I think we'll be moving towards that shortly. You want to try one?
Yeah. Hi, Dr. Victory. Are you guys doing IUI at your clinic these days?
So we're not yet doing IUI at our clinic. We were just about to begin, and my staff felt that we really should wait for formal guidance. In addition, during that conference call last week with the other IVF directors, the suggestion is that anything that happens right now from a medical legal perspective, which we obviously have to be careful with and respect, is not likely to be challenged because we're in the middle of this crisis and no one's really going to question what happens. But moving towards reopening, anything you do that is considered a mistake or done in error or not safe enough, we are all at medical legal risk for. I cannot jeopardize either our center or my staff or myself. And so we need to do this with everybody in Canada so that we are all taking the same step together. And I think that's the safest way. There is undoubtedly momentum and pressure for all of us to restart, to accommodate patients and to accommodate our staff and to, maintain our services. There is definitely a patient care element of this. There is undeniably an economics standpoint to this as well. And we got lots of people that work for us and that depend on us for their families. And so we have to look after all of you. But that's a complex equation, and so we're looking at all of the numbers and pieces to plug in to make sure we get the right answer at the end of that. So we are moving towards restarting. We anticipate it'll probably be at the end of April, and I think by that point we should be safe. Victory Reproductive Care has invested a huge amount into safety equipment. We have special air filtration units from a company called Novaris. These are known to kill previous coronaviruses, and it pretty much annihilates anything that gets suctioned through this. It's constantly recycling the air. We've put it in our lab, in our high traffic areas, dedicated units in each of the patient rooms, plus in the ultrasound room and near the blood draw area. So we are taking great precautions. The rooms get wiped down with Cava wipes between each patient. God bless my staff. I love all of you for all your hard work and commitment and for exposing yourselves. We are all wearing masks. I actually feel like my nose is broken from that N95 mask. I had it on all last night on call and then all day today. Yeah, we are taking every step and precaution that we can to make sure that we are keeping the place as safe and as clean as we absolutely possibly can. So I think moving forward, we will be in a circumstance and a scenario where we can reopen.
So when would you give the HCG shot with a letrozole cycle?
So
and there's a follow-up as well. And when would an Hcg trigger shot improve your chances if you were doing a letrozole cycle with timed intercourse, same person?
Yeah, so timed intercourse versus insemination won't make a difference. The timing of the intercourse versus the insemination is the same. You want to do it about 24 hours after you've naturally triggered. So the timing of the HCG would be precisely at the same time that you get your urinary trigger. So in other words, if you're monitoring with the ovulation kits, which are just those dipsticks that you pee on or dip into your urine, and it tells you that you're positive, they often have two dark lines or a happy face. You use that as your symbol to know that your body is naturally getting ready to release, you take your HCG shot at the same time and you have intercourse the next day. It's definitely okay to have it every day as well, so you could have it that same day, the next day, and the day after, and that'll optimize your choices. You don't want to do that for more than about 4 or 5 days, because then the sperm count and quality start to go down. But during those initial ones, that's perfectly fine. That's a good time to do it. So first 2 or 3 are reasonable. Sperm can actually live inside a woman for up to about 3 days, so it's a very reasonable time to approach that. Let me take one of these. Okay, so this is back to Facebook. I would like to try every trick in the book to make sure we have tried everything to make a successful frozen embryo transfer. How can I make sure my treatment plan is personalized to me and not a generalized plan for everyone? I have had different measures needed than the normal. Well, ideally every patient is individualized, there's no question, but we also need to make sure we're following the general principles. So every patient needs their lining prepared, and that requires a combination of exposure to estrogen, whether it's natural or stimulated, plus exposure to progesterone. The extra elements beyond that involve things like whether or not you're on aspirin or antibiotics. Is your lining ready? Have we taken care of infections, endometriosis? Have we made sure your vitamin levels are optimal? Have we made sure that your vitamin D levels are really good, that you're staying on all of the medications you need to? Have we made sure that there are no signs of any immunological problems, inflammatory problems? So in that regard, there are lots of little tweaks that can be individualized for you, and it's our job to make sure that we are custom tailoring it to you. In general, we tend to take a fairly simple approach the first time, unless you have a very limited number of embryos. But we'll take like a general approach, because the sort of overall gestalt from all of this is we don't want to overdo the things that we're doing for patients. We really want to focus on offering you approaches that are generalizable and that we know have a tried and true history of success. But if you have a limited number of embryos, or if we think that there is something unique about you that we know about from before, so problems with previous cycles, a history of endometriosis, previous infections, biopsy-proven abnormalities, that kind of thing, then those are all situations and circumstances during which we would individualize your care and make sure that we're treating you as a person, not just as a sort of group of people. So, that's something you talk to us about, or you talk to your physician about, and make sure it's planned just for you. Does the Sarnia Clinic have their own funded cycle amount list in terms of number of funded cycles, or would it be put together with your Windsor clinic? So we've always allocated some of what was given to our clinic, that being VRC, to our Sarnia Clinic. And that will continue to occur as long as we have funding. So yeah, we've always done those two together, and we've tried to manage it as fairly as we could based on volumes of patients and needs in those two communities. We have applied to the government. We are hopeful that they will provide us with funding for our Windsor IVF program, but we haven't heard yet, and the application did go in several weeks ago. So we are awaiting a response. I am hoping that they're calculating things. Lots of thumbs up for that. And, obviously write to your local MPPs, write to the Minister of Health, write to the Health Services branch of the Ministry of Health, get them to help us with this. The more pressure that goes on them, the better we will do, and we will likely be mounting sort of a public effort campaign very shortly under the amazing leadership of Tarek Ibrahim to get that going. And we've already had some steps in that direction, so we are feeling hopeful that that can happen. You want to take one?
After 2 failed IUIs, we wanted to try IVF. My OB said absolutely not until we do our 3rd IUI. Is this common practice?
No, I don't think there's anything well, I can only speak to myself. So I never force people into anything. I always want it to be your educated and informed decision. So my belief is you guys should be offered all of the available choices and then make an informed decision based on the best possible evidence for you. So in the same light that the previous question from Facebook was asking about what someone can do to make sure they have an individualized cycle, this is the exact same response. I want your care to be individualized for you. I want you to get an answer that applies to you. So for some patients, after 2 cycles, they're either frustrated or didn't get the outcome that they want, or maybe there are factors that are important to consider. Age, impending diagnosis of something else, like someone's going through cancer treatment, or frustration or diminished ovarian reserve. I mean, there can be a million different things. It may have to do with male factor, declining sperm quality. So regardless of which one of those it is, we always want you to be able to make the decision that is best suited to you so that you're making a decision that is optimal for you. I can't decide for every single patient what is best for them. You are best equipped to make the best decision for you. So no, there's no rule that says you must do 3 IUIs before you go to IVF. We did institute a 3 IUI rule before we put people into government funding, but that was because before that we had a 3-year wait list for IVF, and we had to find a way to minimize that wait list. So we said it's a reasonable choice to ask people to do 3 cycles of IUI before they went on to an IVF wait list. But if you came in and you said you wanted to do it privately, we certainly don't make people wait. And we're willing to go ahead and help you in that regard at any point that you feel is optimal for you.
What's the average duration from consult to transfer on average? Also, can you post this live right after, since I'm able to watch right now?
Yeah. So we post all our lives right after. Subscribe, comment, share. That's hugely important, but they are immediately live on Instagram. They're on Facebook as well. And then we put all of them on our YouTube channel within a couple of days. What's the average? About 4 or 5 days?
Yeah.
Yeah, about 4 or 5 days later, it'll be on YouTube. All of our previous ones are. So you can catch our show there on reruns with little edits that have the start of our show with the sperm and the egg that connect together. So for sure you can watch the show live, replayed later on. And the average time from consult to IVF, if you needed IVF, probably somewhere in the neighborhood of about 2.5 months. That's to get your testing done, to get your plan in place, to make sure everything's ready, and then go ahead and do the treatment. Okay. Am I doing IUI at our clinic these days? We already answered that. Hopefully by the end of the month we would be. Hi, Dr. Victory. For your patients that are using donor sperm for IUI, do you have any idea when the donor clinics will start shipping again? No, we don't know yet. Although I did hear from a recent patient that there is one shipping company that has started again. There is tremendous economic pressures to get the economy moving. It is impossible to stay closed for much longer without sacrificing everything, and I mean everything. So I think that there will be movement towards getting things to occur, and I think the pressure is there for sure. So I suspect shipping companies, cryo shipping companies, every kind of company out there will slowly start to re-engage over the next couple of months. I don't know that it's going to happen tomorrow, but it's going to happen hopefully fairly soon. Let me do one more. Are there long-term effects from the medications needed for an egg retrieval? Maximum doses of Gonal-F and Menopur and third retrieval. No. So to the best of our knowledge, and this has been looked at many, many, many times, fertility treatments do not cause any kind of adverse effects. Mainly cancer is the one that's being looked at. There is no evidence that it increases cancer rates. The diagnosis of infertility can have an impact. on associations with various types of cancer, but the treatments do not. There was a very well done Stanford study looking at, I think, 27,000 patients in total. It realistically, definitively answered that question. There is a small subset of an extremely rare type of cancer that is associated with endometriosis, but I've never seen that kind of cancer before in any patient with endometriosis. So it's pretty rare. We're not seeing that very commonly. So that's the only time where we get at all concerned about it. But otherwise, there are people in the US that do 6, 8, 10 cycles of IVF. In Australia, apparently it's done even more, and nobody's showing up with any problems.
Hi, Dr. Vickery. For how many weeks can bleeding, spotting last after a miscarriage? Thanks.
Well, that's a quickie. So bleeding and spotting can last for anywhere from about normally a minimum of 2 up to a maximum of about 6 weeks. If you're still bleeding heavily past 2 weeks, you probably need to see your doctor. And if you're spotting a little bit, but it's completely not going away after 6 weeks, or you're still persisting with heavy bleeding, then that should be checked out as well. The one exception is most women will get their period around that 6 week mark. So if you do notice another big bleed, but then it trails off, that's just your menstrual cycle resuming.
Okay. I pray for your staff to stay safe.
Thank you. I pray for all of them too. Staff, stay safe, and I love you all. Oh, let me take this brief opportunity because this is a good segue. I need to thank some folks in town here that have supported us. I don't want to specifically get into names because I don't have permission to mention anybody. But there have been some amazing community members who have donated masks to us, including face shields and the face masks, like the medical ones we use in the OR. And I cannot thank you enough for doing so. That means a lot to all of our patients, all of our staff. I also have to put a huge shout out, and I need you all to put out tons and tons of likes for this. My mom sewed over 100 masks, I think, for us to give to our obstetrical patients when they come in on the OB day, and we use them today. She did them all by hand herself. She drove from Toronto to London, met my wife and my daughter, exchanged the mask, didn't even get to hug anybody, and then turned around and drove all the way back, and she is still producing more. So Mom, God bless you. You are an angel, and I love you to death. Most incredible person I've ever known, most amazing woman I've ever known. If I can be 1/10 of who she is now, I will happily die a happy guy. So she's incredible. So thank you, Mom, for making all of those amazing masks, and hopefully the patients today got good use out of them. We are sterilizing them and reusing them. I think several of them actually walked off with the patients. So I think they were a big hit. Mom, you'll probably need to make more.
How much is IUI in your clinic? Thank you.
$350 Canadian for a normal IUI. If you're using the Zymo technique, which is a device that we use to reduce sperm DNA fragmentation, that's $450. It's literally the extra cost of the device itself.
Okay. I have blocked tubes and was told my only option was to undergo IVF. Is it possible to try to unblock my tubes when I try IUI? Then try IUI. Unblock my tubes, then try IUI.
Yeah, it is possible to unblock tubes. It is not very successful. And right now we have to send you to Toronto. It requires an interventional radiologist. They got to do an x-ray, pour dye kind of into your uterus. The dye goes in. They have a wire that goes in. And then at the tip of the wire, there's this little ball. The ball is used to kind of break through the scarring in your tube. It has about a 40% success rate. 60% of the time, even if your tube reopens, it will block off again, and then that can be quite immediate within 24 hours. So it's not something we generally recommend. If your tubes are truly blocked, you probably do need IVF. We're certainly happy to try the other approach for you if that's what you want to do, but you need to have a real solid, robust discussion to know that it likely will not work for you.
Is there a difference? Because there's another question follow up with one block tube versus
versus two.
Yeah,
as long as you have one open tube, you can still get pregnant. And in fact, there's some evidence that one tube can pick up eggs from both sides. So you don't have to have two tubes. You just need to have one tube open, as long as that tube is functional. So if your tube on the other side is blocked because you had a bad infection, there's a fair degree of likelihood that the other tube is also damaged to the point where it won't work, even though it may be open. So the tube doesn't have to just be open, it has to be functional. Let me check and see if we have any questions on this one. I have an Iui question. Can you make a draft of what to say for the pressure to them? Yeah, you know what? Tarek and I will craft something and put it on www.drvictory.com. You guys can go there, print it off, put your names on it, and send it in. We can do that this weekend.
Make a whole form.
Yeah, we'll make a whole form for you guys. So we'll take care of that by this weekend. You guys can all pressure Tarek. Okay, I'm going to take another question. Can patients work with your office and obtain donor eggs through a service such as Egg Helpers or Tiny Feet, as opposed to using a donor known to them? Oh yeah, absolutely. So we have a very good relationship with Egg Helpers. And we are more than happy to introduce you to a donor agency. We do a lot of donor cycles, and yeah, you can come to us and we will do the intro. I speak with the owner of Egg Helpers at least a couple of times a week, and all of his staff. We work really, really closely with them, have had nothing but good experiences with them, and so that's something that's very easy for us to manage for you guys. Donors, surrogacy, not a problem. We work with multiple agencies, and we're more than happy to help you guys in that regard. That's not a problem at all. What vitamins do we recommend in preparation for an IUI? Vitamin D for sure, your prenatal vitamin, iron, omega-3 fatty acids, as many antioxidants as you can cram in there, coenzyme Q10. Those are the basics. Those are the ones you really need. Can we order HCG shots on the phone? Get well soon. Yeah, we can speak to you about what's going on in your cycle, and we can order the HCG shot for you because we're doing virtual visits all the time now. So if that's what you mean, yes. You can't just call in if you're not a patient and say, I want an HCG shot. But as long as you're a patient, yeah, we can work that out. My mom is great. Thank you. Yes, I agree. And thank you for saying feel better soon. Go ahead.
Yeah. So how often do you see silent endometriosis or endo with absolutely no symptoms other than fertility struggles?
So how often is it common to see endo with no symptom other than fertility struggles? So most commonly that's detected when you have unexplained infertility. The main issue is that about 40% of endometriosis cases are silent. So we don't know that the women have them. And they anticipate that somewhere around 15 to 20% of women have endo. So overall, you're looking at probably around 8 to 10, 15% that might have endometriosis out of the whole population that is silent. So yeah, I mean, it's a substantial number of women for sure. It's pretty common. When you have unexplained infertility, it is quite common to find out that there is endo there. And certainly if you have symptoms, pain, painful bleeding, pain with intercourse, the number goes way up. It's much higher chances.
If we haven't been prescribed HCG for our IUI with you, can we get it added on?
Yeah. So, and someone's just asking about that too in terms of cost. So the trigger shot, I think, is around $100 to $110. So it adds a little bit onto the cost. Most people's drug companies cover it. So it should be covered if you have third-party insurance, and hopefully many of you do. And yeah, absolutely. I've already asked Sarah and Lisa to implement that into our protocol. So from now on, anyone doing Clomid or Letrozole who is going to naturally surge and wasn't being monitored will also take home a trigger shot in order to do the trigger. And you're adding about $100, $110 for that. Let me take one from here. I have an initial appointment coming up. Should I prepare for the appointment to be postponed? No, you should not prepare to be postponed, we're just doing them virtually. So I either do it via video like this, or we just do a telephone call, and we go over everything by phone. Then we initiate the protocol to do your testing, and we are still open for testing. We're just spacing everybody out, and as I mentioned earlier, taking tremendous precautions to make sure that we are prioritizing your safety and our staff safety as well.
I have had 2 surgeries, and you have removed endo both times. Chance of it coming back?
Oh, so if you had endo twice, there's a good chance it's going to keep coming back. There are suppressive medications we can use, but all of those interfere with your ability to get pregnant. Estimates usually are on the 30 to 40% range for recurrence of endometriosis, no matter what we do to treat it. So yeah, there is a substantial recurrence rate, unfortunately. I think that's all I got too. Let's see. I think we stumped you guys for once. Wow, what a wonderful mother. Yes, mom is amazing. Okay, so are there any other questions out there before we sign off a little early tonight? Sorry for the crazy, number of cameras I've had to look at all night. I probably made you guys dizzy. It looks like Wimbledon here. I keep looking between the cameras. But it'll be smoother next week. We will probably just have the 2 cameras, and we'll go from there. When is the next live chat? Was it Monday or Tuesday for next week?
I think it was Monday, if I remember correctly.
I think it is Monday. So I think we're doing Monday next week. We will post shortly and put it up for you guys, and then go from there.
I got a couple last minute questions coming.
Okay, last minute questions. All right.
Is there anything to be done for endo aside from surgery?
So there are natural approaches. So those are things like N-acetylcysteine, which Jen Strong, our naturopath, will tell you works. Some people believe in turmeric. And there's some evidence that it may be beneficial. It's not great evidence, but there's some evidence there that it may be helpful. And then avoiding things that have lots of hormone products in them. So especially meats and things like that have been treated. There are medical options, which, as I mentioned a moment ago, all interfere with your ability to get pregnant while you're using them, but you can go on them and then come off of them. And that will actually allow you to get pregnant with an improved chance. So as an example, if you go on Lupron and Letrozole for a couple of months, it'll suppress your estrogen levels. That will drastically decrease the amount of endo and the intensity of the endo. Hopefully do its best to deactivate the endo, and that then improves your chances of getting pregnant by giving you a much higher chance with less inflammation being present. And then there's the surgical option where we go in and we remove or cauterize it. There's a whole field of patients out there on endo blogs that believe that it should only be removed. There is data on that, and the data shows that there is literally a 1% difference between burning and removing. So it is negligible and it is not clinically significant. I think either method is fine. People get really hung up on this stuff. There are some very anti-Lupron people out there. There are some very anti-cauterization people out there. Again, I think that it's a discussion you have with your surgeon or with your REI or your gynecologist, and whatever you guys think is best for you. That's what we do based on what you feel is going to work the best, and good information from us. We have to know the stats. Not everybody has looked it up to know that there's only a 1% difference. So it's really important to have that discussion with the patient, go through the discussion and the options. And, sometimes patients make choices or want things that may not make medical sense, but that's what they want to do. And again, you have to point out to them, this may not make the most medical sense, but if that's what they want to do, you got to give people their ability to, make a choice that's right for them. I got one here. How do you determine if IUI is the best course of action? Okay. So when you're with us, we give you all of your choices from A to Z. It could be something as simple as have more sex, take more vitamins, or in some cases have less sex, take more vitamins, and go all the way out to IVF. And in between there are the things like surgery, insemination with natural ovulation, with pills, or with shots. So which option is the best very much depends on you yourself. If you are much older, if you have already tried multiple cycles of IUI, if you have really severe endo, if the sperm is very compromised, it's probably not the ideal choice for you. On the other hand, if your case is fairly simple, you've never tried it before, the sperm is not that compromised, I would fully support trying IUI. So we give you your options. We help educate you about what's going on with you and what your choices are. And then we very, very much recognize and respect the fact that for all of you, fertility represents a loss of control, and we very much want you guys in control. I jokingly tell patients nobody wants me there in the bedroom with them to make decisions for them. So you need to make decisions for your healthcare that are good for you. And so we give you the education, we give you the options, and then I'm here to support your decision-making process. So is all of our team, the psychologist, the social worker, we have an addiction specialist now, a naturopath, we got a family doc that does counseling, we've got a dietitian. So our whole team and our nurses and all the staff here are designed to help you guys through your own decision-making process. We can certainly guide you on what's the best way to make that decision or what we feel is best for you, but ultimately that decision has to rest on your shoulders, and we'll help you out with that.
I got a bunch of questions after I got them.
All right, we got 11 minutes left. Go for it.
Okay. When should I stop horseback riding while pregnant?
Oh, God. I would not horseback ride while pregnant, especially if you're doing trotting or galloping. I did do a lot of horseback riding when I was younger. Do not horseback ride. That probably makes very little sense. I wouldn't think that that's safe. If you are posting, for those of you that horseback ride, or you are bouncing up and down in the saddle, that's probably not a great option for pregnancy, so I would probably cease. If it's a real leisurely walking the horse kind of ride, that's probably fine. But if you're trotting, galloping, anything like that, that would not make a lot of sense.
Many talents of riders. What can we do other than surgery if we still want to try and get pregnant? Similar to the other one.
Is that the endo patient? Same one? It depends on...
it is the endo patient.
Yeah, so as I mentioned, all those things we talked about. So there's natural approaches and there's medical approaches.
I've been waiting for surgery date to stretch cervix and do exploratory surgery. Would that be done in the office or hospital? And are surgeries still being scheduled for later dates or on hold? Yeah, so right now, all surgery is on hold. I just got permission to do my first surgery, I think, in about 3 weeks, and it's for a cancer patient. And I actually had to apply and have it reviewed in order to be allowed to operate on a cancer patient. So anything simple like dilating your cervix, they're absolutely not going to allow us to do until this COVID thing blows way over. So all surgeries are on hold, and it is going to be I suspect a fairly long hold, at a minimum months. And I don't want to commit to anything, but at a minimum it'll be months. I got a couple here. Letrozole 2.5 milligrams. I'm late 4 days. Take a pregnancy test. Come on in and we'll do your pregnancy test. And is sciatic nerve pain normal early on at 15 weeks of pregnancy? It can be. There's a really good stretch that Joe Thomas, a local family doc, former chiropractor, taught me. So come on into the clinic and I will show you how to do that, but it will get rid of the sciatic pain. How do you tell if someone needs their cervix dilated?
So we can tell if your cervix needs to be dilated when we try to pass a catheter through there, either at the time of doing your saline infusion sonohysterogram or when we're trying to do an insemination, although I don't normally wait till we're doing the insemination to tell you your cervix is too tight to do an insemination. So we normally will do that early on when we're doing your saline infusion sonohysterogram. And it's actually one of the reasons we do SIS for everybody, because it allows me to test your cervix so we know if it's going to be challenging for the sperm to get through.
I live in Winnipeg. Is it possible for me to come over to your clinic for IUI? What does it entail, please?
Yeah, you can come see us for IUI, no problem at all. We would probably get you ready in Winnipeg. and then we would just have you come in to do your insemination. You'd probably fly to TO, or you could drive, although that would be a long drive. And then it's just a 55-minute flight to Windsor. And if you plan it far enough in advance, it's not particularly expensive. If the flights are up and moving, I would think right now Air Canada must be pretty desperate, so I can't imagine flights are particularly expensive. Yeah, absolutely, we'd be happy to help you out. I would need to talk to you first, do a consult. We can do that virtually like this, again, via video or phone. And then once you're ready to go, we can set everything up for you. We have patients right now. I have multiple patients in France, California, several patients, Australia, Japan, Israel, Spain, Italy, Switzerland. So we're international right now. We help everybody. I actually just recently re-edited the Instagram profile to show that too. So yeah, we can help you from anywhere, and Winnipeg is perfectly fine. Good steak in Winnipeg.
Yeah. What supplements do you recommend for women over 40 or for healthy egg?
So loads of vitamins. Again, the vitamin D, the coenzyme Q10. A lot of antioxidants. Avoidance of everything bad. No smoking, no drinking, no marijuana or any other drug use. Make sure your weight is appropriate. And then you want to take potentially DHEA, the hormone, and possibly human growth hormone. Although it is pricey, there is data that it increases live birth rates. DHEA has never been proven to increase live birth rates, but it does increase the number of eggs you produce. So we do support use of those products as well if you're not making enough eggs. There is no evidence that they improve embryo quality or egg quality, but if you make more eggs, you hopefully make more embryos, which means you end up with a better result ultimately. Again, there's no solid proof of that yet, except for human growth hormone, which has been associated with an increase in live birth rates.
If we are waiting to do a FET, are you scheduling them, or is it in a waiting period?
Yeah, we can't schedule anything because we have to wait for this SOP. So for those of you that are joining us, I am part of the national committee to put together a standard operating procedure to get the fertility centers back up and running. I promise I will share it with you as soon as we know what's going on. We're just trying to organize our first meeting. So we are moving forwards. There is lots of support. There is enormous pressure to do this. So believe me, we are all on board. It's a matter of getting it done. How many milligrams of CoQ10 do you recommend? It depends on which CoQ10 you're using. There's one by a company called Theralogic, I think, which was so strong it gave all of our patients a rash, but they only needed 125 milligrams. Typically, you need about 600 to get the right amount to absorb. It is horribly, horribly, poorly absorbed into your system. Okay, I think we are at the end. Any last questions? And if not, we are going to sign off. I want to thank everybody for watching. Huge likes to all of you who have supported our show and have watched every week faithfully. I love you all. Please stay safe. Remember the masks, the hand sanitizer, the hand washing, the social distancing. These are imperative. It is so crucial to getting our world back. I cannot even begin to tell you. So those of you that have come into clinic have seen me. I am covered in an N95 mask. I feel like I'm getting bruised right here from wearing it. I had it on for almost 24 hours, but nevertheless, it is crucial that you have that on. And believe me, I'm not wearing it for me. After 24 hours in that thing, I'm actually ready to expose myself to something awful, but it's to protect you guys. I don't want you guys having me give you anything because I'm seeing one patient and then going on to the next. This is for me to protect everybody else out there from getting anything they don't want to get. Okay, real quick. What do we have? 3 minutes? I got 2 questions. Is there such a thing as embryos being frozen too long? No. The longest embryo transfer that was successful on record is 26 years. So unless you're going past 26, the answer is no. Dr. V just jumped on to say, thank you for everything you do. You truly make dreams come true. My baby turns 1 tomorrow. Thanks to you. You are amazing.
Hi Dee, I love you back. And thank you for saying such nice things. You are amazing as well. So thank you for saying such a wonderful thing. That's awesome. What do you have?
Are there any natural ways to dilate a cervix?
No, there are no natural ways to dilate a cervix. There are natural times in your cycle when you are more dilated right during your period, but you can't get pregnant during your period for obvious reasons. So no, there is no natural way to dilate it. There is a technique we can use with something called a laminaria tent, which is actually dried seaweed wrapped up really, really tight on a piece of bamboo, and you kind of stick it into the cervix, and then it absorbs water and it expands. The problem is most women's cervices are so tight when they are tight that you can't even get that in. But it is natural and it does work. So if you want us to try that, we can. We keep some of those here. Okay, it's time to sign off before we get booted off. Thank you again for all of you that are watching. Fact or Fiction this week was about HCG. We are implementing these changes. This is why I love this show. It is making us help you guys, better. And we are implementing the changes to make things better. So don't hesitate. If you guys have anything you want me to talk about, I'm more than happy to do so. As always, comment, share, like, and subscribe. We need that to get the channel to grow, especially on YouTube. And hopefully we will be unblocked on the 19th for Instagram, and I will start growing that again. Have a great night, everybody. Stay safe. And Mom, thanks again. I love you to death.